terms of nausea, for example, occasionally vomiting, and in terms of lack of response in some patients. If you then switch to subcut methotrexate, excuse me, there are significant benefits. The nausea often goes away and allows you to continue what might be otherwise effective treatment in some individuals. So this just repeats what I've said earlier, that there is a superiority of combination therapy over monotherapy when it comes to disease-modifying drugs for rheumatoid. The COBRA study often quoted combination therapy in rheumatoid arthritis. Showed that a combination of methotrexate with sulfasalazine and high-dose steroid, high dose in this particular study, 60 milligrams a day, tapered every 6 weeks and stopped at 6 months, when compared with sulfasalazine alone, produced much better results in terms of fewer erosions and less disability. And this graph, this chart just illustrates the same. You'll see the top bright green line shows the results, that is severity of disease, clinical outcome, measuring erosive change and disability against time, going up to 56 weeks. That with disease with sulfasalazine alone, the results were nothing like as good as when combination therapy was used. And this just illustrates the same point, looking specifically at the changes on X-ray. The Sharp score, which is a measure of X-ray change, measured up against time, 5 years. Look at the difference between sulfasalazine alone and combination therapy. BEST study, another often quoted study from 2005 from the Dutch group, who've done a lot of work on early rheumatoid arthritis. They looked at 508 patients with rheumatoid with disease within 2 years, followed over a 2-year period, and they produced 4 groups, or divided the patients into 4 groups. Group 1 was sequential monotherapy. Group 2, step-up combination therapy. Group 3, similar to the COBRA, initial combination therapy of tapered high-dose prednisolone, and the alternative, instead of prednisolone, infliximab. And in Group 3, the results were much better in terms of rapid clinical and functional outcome, and lower risk of having progressive disease. And interestingly, there was no significant difference between adverse events and withdrawals between the groups. I think that this just talks about what I've said already about what to do if the patient doesn't respond to methotrexate. Anti-TNF drugs, I wasn't going to dwell on at great length because there are some of the later talks this morning which address this subject. But they, as you will all know, are making a huge difference to patients with active rheumatoid arthritis who've failed in terms of response to conventional treatments. And up to 10% of patients with rheumatoid may require this therapy. In Basingstoke, for example, our catchment population is almost 300,000, and we now have about 320, so roughly 10% of our patients with rheumatoid on disease-modifying drugs. Cost, as you'll know, is exorbitant. Not many of them are less, apart from rituximab, which I know you've done a lot of work on. And in the UK, we're very much held by NICE guidelines, National Institute of Health and Clinical Excellence, in terms of who we can treat. That patients given anti-TNF drugs have to have been shown to have failed to respond to at least 2 conventional disease-modifying drugs, one of which must be methotrexate. Things have got even tighter, actually, nationally in the UK recently, so that we now have to document all of our patients very carefully and justify our initiation of such treatments and their continued use, so that DAS scores, disease activity scores, have to be recorded regularly. And we don't get funding unless all of this is available on paper. The DAS score being, as most of you will know, combination factors, that is a 28 joint count, looking at 28 joints, looking at number of swollen joints, number of tender joints, patient global assessment, the patient's assessment as to how they are, and an inflammatory marker, the ESR, the C-reactive protein. And via an equation you produce a score which needs to be over 5.1 to qualify as disease-modifying drug use. You need to be able to show a reduction of 1.2 to be able to continue with such treatment. Remission is a score of 2.6. Now, these are the biological agents that we use regularly. Etanercept was first available to our unit because it was available free of charge for our trials. So we've got quite a few patients on etanercept. You'll know that's given by weekly subcutaneous injection. We've got a fair few on infliximab, not as many as the subcutaneous injectables, just because it's easier for the patients. And we're starting to introduce Cimzia, which I mentioned briefly in a minute, golimumab, tocilizumab. Abatacept has shown some promise, but